Okay? Yeah. So I'm going to wait. Yeah, maybe. Okay, so we are going to start the last part of this great symposium. I'm Jennifer Molina. I'm the Vet Scientific Affairs Manager in the European team of Purina. And, yeah, first, before introducing our next great speaker, I'm going to give you some details. Well, again, just remind you, like, phones should be switched off to silence. The toilets, I think everyone knows already where the toilets are, right? And the question to the speakers, please take the opportunity to ask questions to these great speakers that we have. And for the virtual attendees, they can send it by the chat function. And just for knowing for everyone, the lectures will be recorded and available after the symposium as well. So, without further delay, I'm going to introduce our next speaker, Dr. Westropp. She obtained her DVM at The Ohio State University in 1997. She then moved to New York City for a one-year internship in small animal medicine and surgery at the Animal Medical Center and returned to Ohio State for her internal medicine residency and PhD training. She was board certified in the American College of Veterinary Internal Medicine in 2001 and completed her PhD in 2004. She's currently professor in the Department of Veterinary Medicine and Epidemiology at the University of California, Davis School of Veterinary Medicine, and her primary research focus is lower urinary tract disorders in dogs and cats, and she's also the director of the V-Link Urinary Stone Analysis Lab at the UC Davis and director of the Veterinary Medical Continuing Education as well in the UC Davis. So we are going to enjoy two lectures from Dr. Jodi Westropp today. The first one on the diagnostic approach to urolithiasis. So welcome to the stage, Jodi.
Thank you so much, Jennifer, for that warm introduction. And I'd like to thank the ESVNU for inviting me here to speak today. And of course, to our sponsors, and Purina, I think, is sponsoring the session in particular. And it's very nice to be here to see some faces I haven't seen in quite some time and to be able to reconnect with some people again in person, which has just been really nice as I think we all start to gather and talk about what's going on and how we can move things forward. All right, so here's my speaker disclosures. I'm going to mention one study very briefly where the supplies were provided by the company, but they did not have any input in the study design or the manuscript or the publication of it. You know, when I had this title, my diagnostic approach to urolithiasis, I mentioned to a few of you, I thought, well, I can do a urinalysis and a radiograph, but I didn't think that was enough for 40 minutes. So I'm sorry, you are gonna have to stay through it. I know that, Dottie may have lectured right before lunch, which is important, but now I have to lecture right before cocktail hour, maybe more important. I will do my best to stay on time. I'm gonna review some data that we obtained from our laboratory at UC Davis. And this was when we had Dr. Lucy Kopechny with us. She was a fellow under Dr. Carrie Palm in hemodialysis fellowship. And of course, I got to work too with Dr. Segev, who I always enjoy collaborating with. And we did a retrospective study looking at the evaluation of trends in urolith composition in both dogs and cats over roughly a 12-year time period. And in that study, we looked at signalment, including their breed, the age, stone location, looking for risk factors for urolithiasis. And one thing I think we all need to remember in these types of studies, it can be a very biased population. Because, right, that animal you have to have the owner actually bring that pet into the vet, and then they have to be willing, and the vet has to take the stones out, and then the veterinarian has to send those stones to our laboratory to be analyzed. And especially when we're looking at forms, right, the breed in particular, if we're looking at-risk breeds, we're very reliant upon the owner to tell us what their breed is, and sometimes they're not exactly right. They over-exaggerate what they might have. I'll talk a little more in the next session too. Our diet histories are fairly limited on some of these forms, and I'll get on my soapbox in the next session. The nutritionists have trained me well on what to ask for. as I mentioned, I thought, okay, I can talk about diagnostics and get that done very quickly, but instead, I thought we would look at more or less my thought processes for these dogs and cats with stone disease, and what's the rationale for the diagnostics I'm selecting. So we are going to go through a little bit on some of the research that's out there. And I'll let you know, we're going to talk about some diagnostics and general principles that will apply to all the mineral types, and then spend a little bit more of the time in this first session looking at calcium oxalate, probably one of the urolists that I think we all find most frustrating, recurrent, and a little difficult to deal with. And I will briefly in this session just kind of show you where struvite and cysteine fall into that, talking much more about dietary management for those in the second session. All right, so the first thing I think about when I get a patient in with stone disease is, what is the signalment? We all know there are specific breeds that are considered at risk. Now, some are easy. If I get, a Dalmatian, for example, with stones, they're kind of the poster child for hyperuricosuriasia that predisposes them to urate stones. Now, they are one of about 15 hyperuricosuric breeds, things like the English and French Bulldog, the Weimaraner, many others. And when I need to, I just go to the websites and see, what studies have been done. And I love the Veterinary Genetics Laboratory website at UC Davis. They list them all for you and let you know what tests are available. Another one, too, if I see Newfoundlands, clearly they also, too, have abnormalities of inborn error of metabolism that predisposes them to cysteine, again, due to genetic mutations. I know, for example, especially at Minnesota, and Dr. Furrow, she does a lot of work, too, evaluating, say, the miniature Schnauzer. They're always overrepresented in epidemiology studies, and we know, too, that they can be hypercalciuric. And so I think, too, when we start to see, okay, we have these at-risk breeds, maybe we should start looking more at genetics. And my disclaimer is, I'm not only not a nutritionist, I'm not a geneticist, but I will talk about some of the really great work that some others are doing. Intact male dogs. You see an intact male, I will think now particularly about the type 3 androgen-dependent cystinuria when I see stones in an intact male. Again, I'll talk more about that in the second hour. Female dogs, struvite, right? They're usually infection-induced stones, so you're going to think about, okay, culture the urine and see if I can do something about that. This table here shows the age and mineral type for urolists in dogs. And I think what's interesting, if you see the light bars, this is struvite. So struvite has a tendency to decline as age increases. And we have a reciprocal increase. Calcium oxalate usually occurs in middle-aged dogs and in older ones. So age is important. And Dr. Furrow published a paper looking at juvenile onset of calcium oxalate stones. And while calcium oxalate is very rare in the French and English Bulldog, she found that for these particular breeds, they had an increased presentation when they were juveniles, which I think that's pretty interesting too when we're starting to look at, are there different etiologies for calcium oxalate depending on the breed? And in her same study, she showed too that calcium oxalate in the Bichon, another breed that's overrepresented, actually present more in that 7 to 10 year age range. Location, too, can help me a little bit. Most of the time, when we're looking at this table here, this is our location of urolists. I put in cats this time. Most of the time in cats and dogs, the bladders, the stones occur in the lower urinary tract. Probably due to, again, anatomy, they're quadrupeds, it's more gravity dependent. Now, there is some thought, maybe even particular with calcium oxalate, that the actual defect and the biomineralization defect starts in the kidney. Maybe there's precipitation of nanoparticles and apatite crystals that set up a Randall's plaque, and calcium oxalate can form, but might continue to develop in the bladder. If you see radiodense stones in a cat in the upper tract, they're going to be calcium oxalate. That is not true for dogs. Dogs can get any type of mineral in their upper tract. These other minerals you see in the cat, these usually were co-precipitates with calcium oxalate, so they were not pure stones. That's how our lab analyzes them, a little bit different than others. The other stone you see there in the upper tract of cats are called dried solidified bloodstones. Those are unique to cats. They can be in the upper or the lower urinary tract, but they're not radiodense. So you only see those on ultrasound or CT. I wasn't quite sure where to put this slide, but I didn't want to forget part of my intake form is, was this an incidental finding or is the animal clinical from this urolithiasis? Because it was written too in the ACVIM consensus statement on urolithiasis, we don't always have to remove the uroliths if they're not causing issues. And that's particularly true, say, for upper tract stones if they're not causing obstruction, because I think we cause more harm than good in some of those cases. But we do need to document, are they complicated by infection? Are they causing obstruction? Are they growing? And if that's the case, and we're monitoring those by either radiography or by ultrasound, particularly for upper tract stones, and if that happens, then we need to intervene. Physical exam, obviously always important. The most important thing I think we do as veterinarians, palpating kidney and bladder. Are they painful? Are they enlarged? How clinical is that pet? It's really always nice weather where we live in California. I love to take particularly our dogs outside to walk them out, get some fresh air, but I tell them it's because we want to watch the animal void. And I do. We want to see that urine stream. Does it look good? Is there hematuria the owner didn't notice? Is there stranguria? And if so, then what is the post-void residual volume in that bladder, which can be very helpful in our decision making. Finally, part of the physical exam is make sure we get a good body condition score. And I think photographing the pets is really helpful. And in part, if you end up, adding this to the comorbid condition the pet has and treating the obesity in addition to the stone disease, you can help, reward their progress and show them how well they're doing along the way as far as obesity management. This cat up here too, just so you know, you can see here the excoriations of the hair, and this cat was returning to the clinic periodically for lower urinary tract disease, actually flipped between having FIC and stones, and we could tell this cat was definitely uncomfortable, to say the least, because all that hair was self-excoriation. So I mentioned obesity. It can be considered a risk factor, and it is in humans for stone disease, particularly calcium oxalate. They found an increase in body mass index associated with an increased risk of nephrolithiasis. It could be due to what's called a carbohydrate-induced hypercalciuria. So that can happen and then be a risk factor. There's also in humans, they look at the increased incidence of metabolic disease and metabolic syndrome, I should say, and when you have a bunch of visceral fat, and that can be a risk factor for atherosclerosis, and perhaps there's a theory or hypothesis of causing renal ischemia with some of the atherosclerosis that can again lead to changes in the kidney, precipitation of mineral. So I think there's a lot of different variables we need to address in these animals. In this particular, I thought this paper was quite interesting. They analyzed a lot of stones from cats and dogs in the Netherlands. I just pulled out one piece of a lot of data they had in there. And they had the vets decide if they were overweight or obese, and 42%. I was astounded when I read that, and then in hindsight thought, well, that's probably typical for the patients I see as well. And then this, again, out of Minnesota, they had a study that showed the mean body condition score in dogs with calcium oxalate was significantly increased compared to controls, albeit neither of them were considered obese. But it was still really nice information to get as we start to look at comorbidities in these patients and risk factors. And I think tomorrow when we go to the beginning of the Congress, we're going to hear a fair amount of talks on antimicrobial stewardship. And if we needed another reason to watch our antimicrobial use in animals, well, in humans, they have found increased rates of antibiotic use in humans who had stones. And so it's important to write down all the medications the animal's receiving as well, and could that be playing a role? They have found in one model in rats that have genetic hypercalciuria. They fed them both the same diet, but put them on either ciprofloxacin or a sulfa drug, and found that this really altered the gut microbiome and ended up altering urine chemistry and saturation for stones. And so it's possible that overuse or prolonged use of antimicrobials may actually be a risk factor for stone disease as well. So another reason why I kind of advocate shorter courses when we can do so. And that also brings up the idea of the emerging area looking at stone disease, which is the gut-kidney axis. And some of the really earlier work that was done looking at the gut microbiome had to do with enteric bacteria that can degrade oxalates. So we're primarily looking at calcium oxalate stones. They found that dogs had a decreased amount of oxalobacter, had an increased risk of calcium oxalate stones. But that probably wasn't the whole story, because in other studies, patients formed stones despite having plenty of oxalobacter. And when you really start to dive into the gut microbiome, they found that, oxalobacter, for it to colonize, probably requires a host of other bacteria to support its life as well. So it's much more complicated, but we have lots of experts now starting to dive into this area, which I think is going to be the kind of trend on where we're heading and looking at management for at least calcium oxalate. The other thing I want to bring up is a urinary microbiome. I mean, really, the urine should be sterile. But could it be that there are microorganisms that are there that could be beneficial or harmful? And in humans, they have published a paper looking at, again, this is just a small study showing an increase in Corynebacterium in the renal pelvis of stone formers compared to controls. What I did like about that study is they also looked at urine from the bladder and said it was the same thing, so there's no need to do nephropilocentesis. Dr. Furrow also took a look at stone formers in dogs and 10 controls and did the urogenital microbiome, so they were free catch urine samples. While no significant differences existed between the two groups, the stone formers had an increased prevalence of Acinetobacter. And again, that's been shown to be a risk factor in humans. And just a third study put up there. Again, they're starting to look at the microbiome in other urinary diseases, CKD, cats with FIC. I think we're going to see more of these studies come along in the urinary microbiome field. But I think one thing we need to consider is that a lot of these studies are just 16S RNA gene sequencing. And it's great. It does allow detection at the genus level, and it's cost effective. But it doesn't give any information on the species or the strain, or what's most important, what are these bacteria doing? Are they viable? What's their role? So you're going to start to need more things like metatranscriptomics and other tools to kind of elucidate the function of what your RNA probe is doing. All right, so my summary for kind of my intake is we need to make sure we provide detailed information and having complete histories and the physical exam, including body condition score, photographs if we can get them. And also on laboratory submission forms, I know it's tedious, I know we're all running around, but please try to be complete. Fill in those diet histories, get the information, have a current age. It seems so easy to say that, but when we're doing these retrospective and epidemiologies, it's really nice to be able to have that accurate information. And I'm sorry, you're going to see a lot of gratuitous pictures of my dog. It's the only stuff I had on my phone, so they ended up in here. All right, looking at calcium oxalate and struvite, this was from Dr. Kopechny's papers, and here's the proportion of calcium oxalate and struvite in cats and in dogs over those 12 to 13 years. Now, in cats, we have had a significant increase in struvite being submitted to our laboratory, and other labs have seen the same thing. Now, particularly in the second hour, I'm going to talk about why that's so bad. We don't need to be seeing struvite from the cats. They shouldn't even really be submitted if we try to take care of them. In dogs, we actually see about 50-50 right now, calcium oxalate and struvite being submitted in about equal proportions. And the percent struvite over time has not changed. While it hasn't gone up, it also hasn't gone down. Other thing, when we were doing this paper, I will tell you initially, you know when you get a review back and you submit a paper and you get all grumpy? Well, I initially got the review back, and one of the reviewers just said, can you please, at least in the cat paper, tell me if they're monohydrate or dihydrate calcium oxalate? I was like, I don't want to go do that. Well, I'm really glad I did. It was a very good suggestion. And the reason we at least looked at the cats and said, all right, the cats had about 57% were monohydrate, 43% were mixed. I could find some data in dogs from a laboratory in France. Now, Dr. Ling, who founded the lab, told me, and I found some literature to support this, that the crystal lattice can change over time as urine chemistry changes. So it can go back between the monohydrate and dihydrate forms. And so it doesn't essentially change your treatment strategy. But there is some literature in humans that says, hey, the monohydrate form has an increased incidence of primary hyperoxaluria and low citrate excretion. So maybe at least I think as a researcher, we can go back and at least start to tease these out a little bit and maybe try to correlate that with certain breeds and what we have as we start to learn more. Now, the more basic risk factors that we know, generally calcium oxalate, again, cats and dogs, middle-aged. There is a male predisposition in cats, dogs, and humans. Some of the at-risk breeds are listed here for dogs. In our lab and at UC Davis, the standard poodle and Pomeranian were fairly new, and their odds ratios were much higher than in the past. So that was kind of interesting. While the miniature Schnauzer and Bichon have always been at risk, at our lab now, their odds ratios were a little lower than the past. I don't know if maybe we're just not seeing as many of those breeds now. The French Bulldog's taken everything over. We see a lot of Frenchies. The cat breeds have pretty much remained the same. The Burmese and the Persian are at increased risk. So because breeds are at certain risk and maybe even some younger animals come in with stones, I think genetics has to be a consideration and a risk factor. And of course, as I mentioned, being hypercalciuric, whether that be idiopathic or maybe even from hypercalcemia. Now, everything else you see in blue here are also risk factors, but due to the time, I don't have time to talk about all of those, so I'm going to spend just a few moments on the first two. So again, I'm not a geneticist, but there are definitely studies in humans looking at calcium oxalate in genetics. It's thought in humans to be polygenic in adults, but there is some evidence that hypercalciuria is inherited, and other evidence showing perhaps mutations in genes that can lead to hypercalcemia and or hypercalciuria, and changes in inactivation of vitamin D. And of course, there's other papers too showing in humans that are predisposed that have primary hypocitraturia, a risk factor for calcium oxalate, or mutations in oxalate transport genes. So what do we know in dogs? Not a lot, at least for calcium oxalate. We're really fortunate to know some of the genes for urate and cysteine. Those have been documented and well published, which is really nice for us, and we can screen those breeds. In calcium oxalate, again, we have several breeds at risk. As I mentioned, it's been reported that the juvenile French and English bulldogs were at increased risk. And in that paper, they suggested that maybe this is a highly penetrant monogenic disorder in that breed. I think it's also interesting because we have two breeds of dogs that are hyperuricosuric. And increased uric acid excretion is a risk factor for calcium oxalate stones in humans. Now, I don't know if those are tied together. I think that's kind of a long shot, but again, it's just as we start to learn more about this and move through. Again, too, it's noted more often in male dogs, but we don't generally think that this is dependent upon sex, like I'll talk about with cysteine. So the summary for me in genetics, who does not do genetics, I save the blood. I think it's really important as a community, we need to start getting really large repositories and save DNA and let the experts in this field have a much larger database to work from. And certainly I've saved all from my studies, but I'd really like to start saving them from all the cases that come in. It's expensive. If anyone has money, let me know, okay? We will start this, and it would be great to be multi-institutional, and some places have started that. We don't have a good source yet at Davis for all of our samples. What about hypercalciuria and calcium oxalate? Well, one mechanism, the animal could be hypercalcemic, and then it will go through the ultrafiltrate. You'll end up with calcium in the urine. The three other mechanisms are idiopathic hypercalciuria, which could be resorptive due to skeletal mobilization. It could be due to GI hyperabsorption from the gut, or renal leak, so impaired renal reabsorption. The other, the kind of what you should see on blood work or PTH analysis are listed there. I will tell you clinically, I don't run those very much in my patients that are not hypercalcemic. It can be quite expensive. And this was published by Dr. Koh, who was a big nephrologist in the human world. And I will tell you that oftentimes this just doesn't happen in the clinical patients. But something I think for us to consider, do we need to start analyzing more calcium parameters as we look at idiopathic hypercalciuria? This is some work that Eva did as well, looking at calcium to creatinine ratios in the urine of dogs with calcium oxalate. Picked 3 of the most common breeds, the Schnauzer, the Bichon, and the Shih Tzu. And what they found was an increase in calcium creatinine ratios in the cases compared to controls. So if it was greater than 0.06, that could be significant as far as hypercalciuria. Well, the one thing is that these were spot samples. 24-hour urine is ideal. Who collects 24-hour urine samples from their patients? Yeah, oh, we got a one hand up. Jen and I have done it before, and I'll show you that in the second hour, and it was not easy, and we had the owners do it. If you take the animal and you're doing it in the clinic, right, it's going to sit in a cage, it's going to be stressed, its urine's not going to be the same, it might not eat. It's just not worth it. It's impractical. Certainly, spot samples are not ideal, but right now I think it's what we have, and I think it can be interesting as we move through, and how does that associate with recurrence. So I think we have a little bit more to learn on spot samples as we go around. Certainly, uric acid to creatinine ratio did not appear to correlate well, but we have some preliminary, at least I've been checking some of my dogs using this urine calcium to creatinine and see what happens over time. This study here also looked at abnormalities in calcium and vitamin D. And I love studies that feed my own bias. So I was kind of happy because I always kept seeing ionized calcium in my patients be slightly elevated, albeit maybe within the reference range. It always just bothered me. Maybe if they were just predisposed, though, and that was enough to push them over. Well, in this study, I thought was pretty interesting is the ionized calcium in the dog cases significantly higher than controls, albeit 5.5 to 5.2. Clinically, you might say, well, that's not relevant, but maybe it is. They also looked at a lot of vitamin D parameters and found, too, that there could be an abnormality in degradation of 25 to 25 dihydroxycholecalciferol. Perhaps, again, is there an issue with genetics? Is this an abnormality? It's a little hard. We all struggle with retrospective studies, right? I mean, the diets aren't the same, and it can be a little difficult to interpret. So my summary on this part, I evaluate serum calcium and an ionized calcium, even if the total is normal, in my patients I suspect having calcium oxalate urolithiasis. I consider a calcium creatinine ratio, and if I change something when I'm managing my calcium oxalate patient, like I add hydrochlorothiazide or I change the diet, I'm following up with that calcium creatinine ratio to see what it did, and then also, most importantly, what we care about, did the animal make stones again? And then see what the calcium creatinine ratio is, because that's what I think we're all interested in for the most part. All right, what are other diagnostics for dogs and cats with urolithiasis? Can't forget the urine. It's the best thing. So urine-specific gravity. I like to get it right when the dogs or cats come in. Ideally, we want them to be dilute. You know, less than 10-20 ideally consistently in a dog, less than 10-30 in a cat. If you need to go lower, we go lower. It just depends and tailor it. Remember that crystalluria is not in and of itself a disease, particularly if you do not analyze that urine sediment within an hour or if you refrigerated it, because you can get spontaneous crystallization of especially calcium oxalate and struvite. And so if you are monitoring a stone patient and you send it off to the lab, you just wasted your client's money. You really should be analyzing these in-house. And we have extra things now, right? We can use SediVue or the VET scan. There's other things to make it easier for us, too. Also, one of my residents, who's now my colleague, did a study as well. He just looked at cats with urate stones. And what we found too, which just proved, again, our bias is that even in those cats, the crystal type doesn't always say what the stone is. So, we had cats with urate stones. Most didn't have crystals. I think about 7 had urate crystals, and some had struvite, and the majority had calcium oxalate. Again, the urine's going to change over time during the day, depending on what the animal ate, postprandial, fasted, stressed, etc. If I see urate or cysteine crystals, though, that's where I have a talk with my client and say, we probably should work your animal up. It might depend on the breed. We might change diet for those particular stones, depending on the select breed and species. Urine culture, I culture all my dogs with Urolith regardless of clinical signs, because it's going to help me identify the mineral type. If I get a urease-producing bacteria, I'm going to feel comfortable that at least probably a portion of that stone, if not all of it, might contain struvite. As far as cats go, I don't know that we need to really culture the stones of cats. Most of them are sterile. I will talk a little bit about, in the second hour, some other techniques maybe on research that we might do for that. And I do think, again, regardless of signs, we should culture prior to interventional procedures. It's even recommended in the UTI guidelines that we would treat asymptomatic bacteriuria prior to an interventional procedure on the urinary tract. If you've got a real cost-conscious owner as well, we've been using the rapid back vet quite a bit. This is a point of care test. I'll talk more about this tomorrow, but very briefly, we published a paper looking at it and got well over a 90% sensitivity, 95% specificity with more than 10 to the third CFUs per mil present. Other universities and centers have also published and had nice results with this as well. And it will tell you at least if it's a gram positive, or it'll say gram indeterminate, or of course negative. Blood work, important to do. I do a CBC for a few reasons. One, especially if I have hematuria in a cat and dog, I want to make sure there's no evidence of iron deficiency anemia, especially if it's a slow kind of chronic bleed. And then if I'm worried about pyelo, I just want to make sure, maybe there's an upper tract stone. Is there any evidence of a neutrophilia, left shift suggested for more systemic involvement? And again, particularly with cats and dogs with ureteroliths or obstruction, very important to evaluate for the presence or absence of azotemia. And as I mentioned, I'll do a total and ionized calcium. What about imaging studies? So first of all, do we all know what's the most accurate for stone size? Digital radiography or ultrasonography? Radiography? Anybody for ultrasound? Depends. All right, I'll buy it. The answer is, it's an older paper, but they found digital radiography is more accurate in predicting stone size. Ultrasound can have a tendency to overestimate, in part because I think the little crystals aggregate together and they lump on one another and it looks like a bigger stone when actually it's tons of little ones. And it's really important for me to do radiography. In part, I get the whole urinary tract with the urethra, but if I'm going to do interventional procedures, maybe avoiding hydropropulsion or laser lithotripsy, I want the most accurate size I can tell to see if that procedure is appropriate. We all know by now, what the radiodensity of stones are, but remember too, ultrasound though can be complementary, right? So if you don't see it on radiographs and you see it on ultrasound, it's likely one of the less radiodense mineral types. So I still might have to do an ultrasound, but I always tell my students, they know I'm a cheapskate, right? I try to spend money wisely. Ultrasounds can be really costly too. So plain radiography, what's the problem with this radiograph? Yes, I read mine with my students too. I miss the entire urinary tract back here. So really important to go from the top of the kidney all the way back. Certainly we see all these radiodense cystoliths in this animal. Anybody guess what mineral type this might be? You didn't know there was a quiz in the evening? What do you think? Any guesses? Axolite, did I hear? So there's 2 hints, no pun intended here. This is cysteine. So again, this just goes to show too, I know I was always taught in vet school too, cysteine are not radiodense. Well, they're just less radiodense, particularly when they get larger. You will see them. And again, this was an intact male dog, so cysteine went higher on our list. And these were confirmed. And very important when you're doing radiographs, pull those legs back and pull them forward to get that entire urethra. This dog was blocked, so there's a catheter in there too at the time. We do a lot of paddle shots too. You can see it's just, I call it a paddle shot. I'm sure the radiologists have a better word for it. But it's a wooden spoon. We put it on. It helps push the viscera out of the way so we can see if there's anything overlying it. And then you can see in this particular dog, lots of tiny little sediment and stones sitting there in the bladder. And we call anything 2 millimeters or less sediment, more than 2 millimeters a stone. And we just arbitrarily chose that and put it in a paper. No one questioned it. So imaging summary, plain radiography, I think it's recommended. It's great for planning your interventional procedures, so you know what size these stones are. And I still have a little bit of a deal with our radiologists. They let me do a lateral stone check, and it's less expensive than full view. I think I get what I need. Sorry for the radiologist, I don't have 2 views on all of these. Abdominal ultrasound can be very complimentary, and make sure we include that entire urinary tract. Just finally, this isn't really diagnostics, but it goes along with this. Communication's so important with your stone patients. There's no cure. We have to be a team together, and we work to prevent recurrence. And a lot of people ask me, well, when do you recheck them? I will say initially after I change the diet, if I have to, about a month later after they're consuming that diet well. And then they'll say, well, when after that, 3 months, 6 months? It depends on what happened. And it depends on my owner's finances. It depends on how close they are to me. So we have to practice precision medicine to do the best we can for our patients. And these are my 2 goats. So goats get stones too. I always put them in, just so you know, they get calcium carbonate, but I never like to forget the species. So I have 2 minutes for questions or comments.
Thank you, Jodi. Very clear presentation. So any question from the audience? Yeah, there is one there. The mic. Natalie, at the end.
Hopefully all of you are drinking water right now and preventing your stones. Okay.
It was a great talk. I have questions about the dried solidified blood stones that you have seen in dogs. Well, cats.
Cats.
I've seen one in a dog.
Excellent.
What vessel and what predisposing factors are making them bleed into the renal? I've seen it bilateral.
So we looked in our cats. I think there were, I have to go back and check the paper, maybe 30 some. It's been a while. And a lot of the cats, and I have to look at the percentage, probably 2/3 had some form of at least microscopic hematuria, if not gross hematuria, which would have been probably diagnosed as idiopathic renal hematuria. So we have seen those cases develop these stones. We think at least, and I occasionally have heard, well, we've never gotten one in our lab before. I think cats make them more so than dogs, maybe because their urine's more concentrated and it might solidify out more. These are not blood clots, by the way. You know, I always tell my students, if we take them out, I could throw them at them and hit them. They're not slimy little things. So they are actual stones, and we have done microprobe analysis on them. The only thing we've really found in them for minerals would be, you know, constituents of blood, and, you know, if they had a touch of calcium or oxalate in them, that probe down. So we're not quite certain if it has to do with flow, ischemia, hematuria we missed, and then urine concentration. The only recommendation I can make for treatment is really increase the moisture. And if they are becoming anemic from the hematuria, then we would do something like sclerotherapy or something for that.
Thank you. Any other question? No? Okay. So then I think we can move to the
Round 2.
next one. We are perfectly on time, so congratulations. So yeah.
Again, more gratuitous pictures of my dog, sorry. He had a professional photo shoot done for the school, so I got all the photos, so they went in there. That's Clarence. And again, my disclaimer is, I love this. I was asked to talk on the role of diet in the management of urolithiasis. I'm not a nutritionist, but I work with great ones, and they keep me honest. And they really have taught me too the importance of, looking at food intakes in the diet studies. How do we document that over long term, and making sure too what's compliance. And these are so hard. I agree. These studies can be very difficult to do. But I also collaborate with some urologists in the human medicine over at UCSF and things, and they tell us, they say, well, yes, diet trials are hard to do in humans, but they love the fact that our patients are so much more compliant. We give them a bag of kibble and they stick with it. I don't know about you all, but I have not eaten very well the few days I've been here. I've had a lot of fun and had good food, but it certainly, I wouldn't qualify for a diet study now, So I think we can gain a lot of valuable information for our patients where they can use this as for translational medicine for humans. I did have, Purina did support one of the studies I will show, and Royal Canin another. So some of the topics, we'll go through some dietary management strategies. We'll do an overview, really. So we're going to kind of hit each one and hit the highlights. Looking at struvite, dissolution for cats and dogs. A little bit on some of the primary, or I don't want to say controversial, issues in calcium oxalate dietary management. And then a touch on urate and cysteine. But don't forget as well, animals don't just come in oftentimes with one issue. So we have to make sure if they happen to be obese or they have diabetes, our dietary management needs to address the multiple issues. It needs to address the pet, not just the bladder stone it came in with. So as I mentioned in the last hour, it's important to note too, are there clinical signs or is it incidental? That'll let you know if you're going to remove it or not, first time or second time. If it is a recurrence, it's nice to know too what the previous mineral was, hoping it might be at least similar. It gives you an idea, but realize they can change, and I'll show you that happened in one of our studies in particular. Now, it's really important, particularly when you're trying to figure out what diet to feed the pet, what diet was the pet eating when the stones were actually removed? And then it should include all treats, all supplements, if it's canned, if it's dry, if it's a combination, what is that combination? And I know this seems like very elementary things to put on a slide, but I can't tell you how many times these forms do not have that on there, and they just put unknown. Like, well, so we go back and we have to call. It really does help us quite a bit. And current medications, is the animal on antibiotics? Is it receiving citrate? And then if they flipped it, what is the current diet? And I don't have time to talk about it, but particularly for my cats, what's the environment like? There are some, associations even with stress and urolithiasis, and we certainly know cats and their lower urinary tract disease can be exacerbated by stressful circumstances. Optimizing the indoor environment can be very beneficial, I think. Start with a case. This Lucy, a 10-and-a-half-year-old female spayed lab mix. She presented with stranduria and polacuria. Gotta love urinary cases, right? Forget those critical care stuff. Physical exam, look good. You get to go home at 5. It's not a bad one. But her body condition score was 6 on a 9. And on her, I didn't think I need my glasses. I might. There's a little evidence of microscopic hematuria and pyuria. And on her urine culture, she had more than 10 to the 5th colony-forming units of a staphylococcal species that was fairly susceptible to everything. These were actually her radiographs I showed you. So what do you think she has? Struvite. Pretty good guess. So we suspect struvite. About 85% or so of canine struvite are associated with bacterial cystitis. And they are urease-producing bacteria. The most common bacteria from dogs are Staphylococcus. And in humans, it's usually Proteus. Other microbes that can also have urease capabilities are listed there, albeit the last two are not throughout the species, so it's not always a urease producer. We certainly know that urease can hydrolyze urea, forming ammonia and CO2, increasing the urinary pH. Magnesium, ammonium phosphate fall out of solution. Now, this is for dogs, but feline struvite uroliths are generally sterile. So these are more either dietary type stones, genetics, everything else we need to look at in the cat. Looking at canine, and again, we always put these two together. This is the same slide I showed, struvite and calcium oxalate uroliths. We haven't had any significant change in struvite over time in dogs over this past 12, 13 years here. Struvite had an 18 times increased risk in females, and that makes sense because of their increased risk for urinary tract infections. What about urolith culture results? So in dogs, we cultured 1,435 struvite uroliths. Of those, 600 were positive for growth. We also cultured almost 1,200 appetite-containing uroliths, and 476 were positive. The overwhelming majority were positive with Staphylococcus, not surprising. And when we looked at the data, we had a significant increased proportion of positive cultures from struvite and appetite-containing stones. Now, appetite is a very common co-precipitate with struvite, so this is why we generally see those two together. So, should we be culturing uroliths? I guess my thought is this: if you did not culture the urine, or the urine was negative in the dog, and it's struvite, I think there's advantages to culturing the urolith to see if it's still infection-induced, and somehow we just didn't get it in the urine, we wanted to see again if it's in the stone but not in the urine, and that has been reported. What about other analyses, other stones? I don't know that culturing all of the other stones, I'm going to tell you, for your patients right now, I don't think it's clinically worth it because it's not going to change what we do. If they come back positive and the stones are already out of the animal and the animal's asymptomatic, you're not going to treat it. Okay? But this is some really very preliminary new work. One of my PhD students who I tacked onto, her name is Ashley Flores, and Ashley, I loved it. She was very interested in her first year in vet school looking at equine enteroliths, and they were struvite, and she started doing RNA sequencing on them looking for bacteria. And I was very happy because when she went through her second year urinary course, she said, wow, uroliths are much more exciting. I'm putting words in her mouth a little bit. But she did really like it, so we kind of changed her PhD a little to looking at more biomineralization abnormalities to include enteroliths and uroliths. And she's working closely with Dr. Bart Weimer, who's really good at doing these types of studies. So my mentor always told me, surround yourself with smart people, and I've got the best. I feel very lucky. And what we did is she initially just took, this was her summer research project, she took stones from struvite from dogs and cats and did some deep RNA metagenomic sequencing on them. And not surprisingly, she was able to isolate good samples from the dog, and you can measure how pure a sample is based on kind of its ratio of the organic to content to the protein content. Should be about over 2. But what I found interesting is she also got a really good read from the feline struvite stones as well. So from a research perspective, maybe there's more we can and should be doing. So she's finishing up all of the struvite, and then we're going to move on to calcium oxalate. But as I mentioned in the last talk, what are the bacteria viable? What are they doing? What's the function? And is this clinically relevant from a pathogenesis standpoint? All right, back to Lucy. What's the best therapeutic option for Lucy? Cystotomy and antibiotics, dissolution diet and antibiotics, laser lithotripsy, antibiotics, or a VUH? What do people want to do? I'm seeing 2s. Anybody else? Yeah, good. And it's the diet talk, so I think I gave it away, but there we go. So do we have evidence for that? Fortunately, we have some. We did a study evaluating a dry therapeutic. It was the OXST. We screened 14 dogs. We enrolled 10 of them. You all know the best way to cure a disease is to open a clinical trial because they stop coming in. And so it was hard to recruit them. Our criteria for enrollment may have been a little not ideal in some ways. We said the stone had to be less than 85% of the bladder volume. That was kind of estimated by our radiologist who was a co-author. And then we gave the dogs the dry diet and antimicrobials, and we gave them the antimicrobial throughout the duration of the study. We rechecked them, and primarily the antibiotic was amoxicillin. We rechecked them at 2 weeks, 4 weeks, and then monthly thereafter with radiographs, a urinalysis, a urine culture, and we always included that paddle shot. So looking at our responders, we had a 50% response rate. So 5 of those 10 dogs dissolved their stones completely and they were gone. The median time to duration, 31 days. The range is listed there. Honestly, as the clinician, I don't really care what the time and duration is as long as my dog or cat, for that matter, is asymptomatic and feels good. As long as they're feeling fine, if it takes a little longer, it still beats surgery. This is why I hate the fact that our struvite stones are not changing if we can be dissolving some of them. The median pH was 6.73 in those responders. Largest cystolith, about not quite 3 centimeters. Some of those dogs, too, voided some really small uroliths, and the number ranged anywhere from 1 large one to over 50 plus tiny ones. In the responder group, I did have 1 dog develop a subclinical bacteria with an enterococcus. We did not treat that one. The non-responder dogs. We classified non-responders if they had persistent lower urinary tract signs or lack of dissolution at, I think it was at the 1 month time mark, any change. The median time to failure was 21 days. Some of them did go longer because we were seeing them start to get a little smaller, but then they remained static. So they had to be static, no change within a 1 month time period. 3 of our 5 dogs here were considered clinical failures due to persistent clinical signs. 2 of them even had persistent clinical signs despite NSAIDs or tramadol. So that we just felt we needed to get those removed. The largest stone in the non-responders, 4.5 centimeters, and number of uroliths, 1 to 25. This was one of our non-responders. So again, maybe taking up quite a bit of bladder volume, but if you look closely, there are a lot of little nooks and crannies in there. So we thought maybe the medicated urine could get through and help. And the owner thought their dog signs were reasonable and didn't care, and he just loved coming back. So this was Cupcake. Looking at the urinalysis results, I thought they were interesting. The baseline, there was no significant difference between responders and non-responders. The responders about 7.9, non-responders 7.4. The ranges are there. At the completion of the study, significant decrease but both of them significantly declined, but no difference then between responders and non-responders. They just both significantly dropped. The urine-specific gravity, again, no significant difference at baseline, and we found what I would apply as the opposite results, is that the responders were actually significantly elevated compared to the non-responders. And honestly, we couldn't really explain that. These dogs were not given additional water on their food, which I will show you in another study we did. So it was just the dry diet. Maybe there was other moisture content. I don't know. We tried, owners were pretty compliant. They filled out diet history questionnaires and did every 2 weeks before coming in, they would weigh food for us. So I think that's interesting, and I don't know if that's, again, just a small sample size on what we have. Why do some dogs fail dissolution? Well, in the ACVIM consensus, large solitary cystoliths occupying almost all of the urinary bladder, probably you shouldn't try dissolution. This was a dog we screened. We did not enroll. Modified urine has to kind of get to those uroliths, and that can be difficult. Now, the downside always to a struvite study is you never know the dogs that responded, were they pure struvite? We're never going to know because they're gone. But I can tell you that all the dogs who didn't respond had at least some portion of apatite in their stones. And it's thought that apatite might act as a barrier. A few dogs, too, one had a calcium oxalate core, albeit there was still struvite and apatite in the shell. And one dog had a little bit of urate. What about antimicrobial duration? I said we gave it throughout the dissolution study, and that's primarily because that's still by convention what people are doing. The UTI guidelines did suggest, well, maybe we could do shorter duration. I didn't think that was time to try that in a study. We were testing a diet as well. So, some consideration, should we do antibiotics without diet? I don't really think that's going to be beneficial or be as effective. Possible diet without antimicrobials, but that would worry me. I think one thing we could consider would be a shorter course. And there was a study looking at, again, I believe they gave ciprofloxacin for 7 days, and they did in suspected struvite stone formers. They found, I think, at day 41, the urine pH would have been appropriate for dissolution, but they didn't look at radiographic dissolution in that study. So I think it's an area to explore. I get concerned about bacterial resistance or maybe alterations in the gut microbiome, but whatever you do, it's just important to recheck the dog. And if it's positive, it's still a urease, then go ahead and start antibiotics again. If it's negative or you think it's an asymptomatic bacteria, then maybe we don't treat. Struvite prevention in dogs. Generally, I don't really put dogs on struvite prevention diets because they are caused by bacterial infections. If I have a dog with recurrent UTI getting struvite often, I will generally put them on one of the struvite prevention and hope to kind of combat it a little earlier, if you will. On to feline struvite, it's even worse. Not only are they not the same, it's actually increasing in proportion that are submitted to our laboratory. Very rare. Sometimes they do culture positive, albeit uncommonly. Most of the time, at least for me, those are cats who have had like a PU or other thing that predisposes it to infection. And there is evidence in dogs or in cats for dissolution. The study by Dr. Lappin and his group, 12 cats that he enrolled from a shelter, they had lower urinary tract signs, no evidence of bacteria if they had a urinalysis done, and he had a 42% successful dissolution. That again evaluated the Purina brand. I think that the cats that did not dissolve, they weren't struvite when they were removed. And 2 other studies here looking at Hill's products, SD or CD Multicare, 37 cats, 32 complete urolith dissolution. Again, the other ones that didn't dissolve were not struvite. And again, another one evaluating SO. So I think cats dissolve really quickly. If they are not having good evidence of dissolution at 2 weeks, you can probably take them out. So I hate to see the trend in cats going up. Particularly, we know how much they love coming into the vet and getting surgery and wearing an e-collar, and that's just not fun. All right, what about flipping from struvite? What about dietary principles for calcium oxalate prevention in cats and dogs? Well, likely a multifactorial approach. High moisture diet, as I mentioned, really important. If they won't eat canned food, we can talk a little bit about sodium. I'll mention a bit about pH and lipids. High moisture diet. Ideally, if the pet will eat a canned food, that's best. You'll get anywhere between 70 to 75% moisture. I know that can be cost prohibitive and almost impractical for like a Newfoundland, right? But maybe at least in our cats and small dogs. If not, you can try adding water to dry food. I usually start anywhere 1/2 to 3/4 cup of water per cup of dry food. Let the animal adjust to that, acclimatize for a week. If they're still eating it well, increase the water and trying to get up to about 1.5 to 1, or tailoring it to that pet to see what's necessary. Again, these ideal specific gravities are listed here, but you might need to increase that urine dilution even further in some pets who are really recurrent. So if they won't eat a canned food and you're having trouble with urine dissolution or decreasing urine specific gravity, then sometimes we can consider a higher sodium diet option. Obviously, sodium can stimulate thirst. I think, we need to be a little cautious still if they're in fulminant congestive heart failure. They always say, again, in renal disease, but if I have an animal who has kidney disease, stage 2 or higher, by definition, their urine should be isosonuric. So I don't think that I'm using sodium for that reason anyway. And while animals are not quite as sodium dependent as far as hypertension, I still, if they're fulminantly hypertensive, I avoid the sodium just because I don't know that the risk benefit is there. All right, the concern in humans with sodium intake is it will increase calcium excretion and can be a risk factor for calcium oxalate stones. So here's I picked a few papers looking at cats and dogs. And overall, the top paper, there were 8 cats fed 4 different diets. And I know I did not flip all this to grams per 100 kcal. It is so confusing. You nutritionists, please. But the percent sodium is listed here. They were fed it for 21 days, short-term study, and then they assessed the animal over 7 days. The calcium concentration was constant despite an increased calcium excretion, likely due to the increased urine volume that was noted. The urine pH was actually fairly low in all of the groups of variable sodium diets. The relative supersaturation for calcium oxalate was unchanged. So they thought that this amount of sodium was not going to be detrimental for calcium oxalate patients and could be beneficial because although calcium increased due to the urine dilution, the calcium concentration was lower. In this particular paper, 13 cats and 8 dogs fed 4 different diets for 7 days. The higher sodium diet increased calcium excretion in dogs, but again, decreased calcium concentration. And in that particular study, they also looked at struvite. They found a lower relative supersaturation for both struvite and calcium oxalate. Now, we need longer-term studies, really, to see, but most importantly, we need to know, does RSS correlate with a decreased recurrence? This is where dietary studies are really difficult. And what is recurrence? Is it radiographic recurrence? Is it clinical recurrence? And at what time point should we be checking these? And I'm looking at Dr. Larson because we've tried this, and it is not an easy study to do, and we're regrouping. That's all I'm going to say about it. What about urinary pH? I'm not trying to be controversial, but it might sound like it. This actually came right out of the ACVIM consensus statement. I was on that consensus statement, so it's okay I put it up. But diets and medications designed to promote urine acidification less than 6.5 should be avoided. So how many of you all use some of the diets marketed for calcium oxalate prevention? Yeah, I do too. So they do result in a urinary pH that's less than that. And I think what we meant, like when you look at the studies, it just kind of came out a little bit as dogma and realized consensus statements are not dogma, they're not mandates. And one of the studies was both on retrospective epidemiology data this was based on, and a prospective nice 12-month study looking at 4 healthy cats. They fed them 3 different diets, resulting in pH of either 6.19. We have a 7. What's the neutral diet around 7, alkalinizing a little bit higher. And what they found was the calcium oxalate RSS was significantly lower the more alkalinizing the diet was. That would be beneficial then to not have an acidic diet. But I thought what was interesting about that paper is they didn't see a decline in the RSS for struvite with the lower pH, which I would expect because of all stones, struvite is very pH dependent. Calcium oxalate, there's a little influence on pH, but it's not that drastic. So I think that was probably, to be quite frank, overstated. Here is another paper then looking at RSS and pH. 13 cats sequentially fed 4 different diets for a minimum of 10 days, again, short term. Now, the lower the pH, it resulted in an increased calcium excretion and concentration. That's not great. Lower pH did result, though, in a lower citrate in dogs. That's a risk factor, too. But the lower pH resulted in a decreased urinary oxalate concentration, which overall, the calcium oxalate RSS had no change with the diets of differing pH. They did find a significant decline in RSS for struvite as the pH went down. So I always tell people I don't use a highly acidified diet long term, but I think the diets that we use for calcium oxalate prevention produce an RSS that will be less for struvite and in the appropriate range, and kind of in that low metastable range for calcium oxalate. What about protein? Humans and rodents, there are concerned primarily not just with how much protein, but also the quality. Because dietary hydroxyproline and oxalate intake can affect urinary oxalate. And glyoxylate and oxalate are synthesized endogenously from hydroxyproline. So in this study, they looked at the effects of both high oxalate, high hydroxyproline diets and high hydroxyproline and low oxalate diets. And what they found, it's a surprise. Okay, wait, where am I? This one. Is that even if the animal consumed a very low oxalate diet, if the diet was high in hydroxyproline, the urinary oxalate was quite high. So the quality of protein is very important. Lipids, in humans, I've already alluded to for calcium oxalate, there's some concern about, atherosclerosis and human calcium oxalate. There are no prospective studies in dogs looking at that. We had some preliminary work. We looked at some hyperlipidemic cats. I will tell you, we actually didn't find an increase in calcium or oxalate in the urine in these hyperlipidemic cats. But I'll show you a little bit of data from dogs, and I think in the dog species, primarily two, right, we have the miniature schnauzer, right, predisposed to calcium oxalate, hyperlipidemia, maybe our obese patients. We might need to tailor a more low-fat diet for those particular calcium oxalate patients, and maybe too for our dogs with historical pancreatitis. And this was a paper from Dr. Dunn, I believe, in her group, and they screened dogs with calcium oxalate for triglycerides. And they found about a 3 times increase risk for calcium oxalate for every millimole increase in triglycerides, 2.4 increase for every increase in body condition score. And what they did too is they did tailor it, took the schnauzers out and put the schnauzers in. So you can see the data with and without the miniature schnauzers still significant. So I like to check triglycerides in a lot of my dogs, and I will make sure to tailor my dietary therapy appropriately in those patients. Summary is provided here, and I just want to stress too, again, highly acidifying diets. I know that kind of came out a little, it's an overview too of calcium oxalate and dietary strategies. You could obviously spend days talking about diet and calcium oxalate, and I had about 5 minutes. What about urate? Flip gears here a little bit. Urate certainly, especially I'm just going to talk about urate uroliths and the hyperuricosuric breeds. And it's been found if you reduce dietary protein, that was evaluated in 6 healthy beagles. And Dr. Barges found a decrease in the activity product ratio for uric acid, sodium urate, and ammonium urate, and 24-hour urinary uric acid excretion compared to a higher protein meat-based diet. So this is where the whole principle, I think, came from. We want to restrict protein in these dogs. Well, we also did a study evaluating 9 dogs with hyperuricosuric that had urate stones. As you imagine, most of them were Dalmatians, except for my favorite clinical trial patient, a miniature Dalmatian. He was very cute, and they kept the gene for hyperuricosuric, even though they shrunk the dog. And in this, it's higher protein at 5 grams per 100 kcal. And what we found is a decrease in 24-hour uric acid concentration at 6 and 12 months compared to their baseline values. Show you a little bit more from this study. The urine parameters, I think, again, when you translate some of these, smaller short-term studies into longer-term, 1-year client-owned patients, you get things I can't always explain. The urine pH was significantly lower at 12 months when measured by the meter or the dip strip method. But if we use the pooled sample of the 24-hour urine, the 12-month, there was no difference at 0.07, but it did go up a bit at 7. So at least we got a little alkalinization there. Maybe in some dogs, adding more urinary alkalinizing agents could help them even further. The role of citrate can be a little difficult and variable from animal to animal. No significant difference in the urine-specific gravity over time, which wasn't surprising. We did encourage our clients to add water, and we structured, just like I mentioned, to the dry diet because we know clinically how recurrent these stones can be. Most dogs, regardless, at their rechecks had sand noted on ultrasound. Sand, here's a typical mild sand. Here would be moderate sand with maybe a few small uroliths, and this would be many uroliths with a little bit of sand. 2 dogs in our study had urolith recurrence over the 1-year time period. 1 dog we know for certain was not compliant. The dog ran off in Tahoe, Lake Tahoe area, and it killed a deer and it ate the deer carcass. And she told us, and sure enough, it was after that visit, and that's written in the paper. The dog got stones, and they were urate. 1 dog actually developed calcium oxalate cystilis. So that's why it's important to analyze them. That dog also had nephrolis, but we didn't remove them because he wasn't clinical from them. None of these dogs in this study received allopurinol or any other medications during the 12-month time period. I do not think it's necessary to remove all of these little things if they're staying static because they're going to pop right back, I bet, the next day. So most of these dogs, if they come in like this, we're going to leave that and as long as they're asymptomatic and doing well. Last slide or so on cystine. Most cystine stones occur less than 7 years of age. We do have genetics for them. Mutations have been documented in several different genes, and they're listed there. But the main one I want to just briefly mention is this androgen-dependent type 3 cystinuria that's been described in both the English Bulldog, the French Bulldog, and the English Mastiff. And thank you, Dr. Larson, for the picture of your dogs. So this is some urate and cystine we have. We paired these 2 together because they're by inborn errors in metabolism. We have found an increased proportion of cystine uroliths submitted to our laboratory over time, and a significant nonlinear increase in cystine uroliths for male intact dogs. And other sites have also reported similar findings. We are seeing this in a variety of breeds when they are intact. For us, it was around 75%. Other studies have been even higher. So, is a dietary change warranted if your owners will castrate their dogs? Currently, what a lot of people are doing is castrating the animal, changing the diet to something maybe a vegetarian, HA, or a protein-restricted diet, and for about 3 months or so, and then trying to transition back onto their regular diet and see if they have recurrence. Well, what we're doing is we have an ongoing pilot study that's just about wrapped up, but we are checking their plasma and urinary amino acids pre-castration. We're not changing the diet, and then we're checking their plasma and urinary amino acids at 1 and 3 months later, as well as ultrasounding the animals to look for evidence of recurrence. So trying to tailor that in and see what we have. So I think with this information that should be out soon and where we have some promising results, I think that that'll help guide us a little bit because, again, I'm a cheapskate. The diets can be expensive, and it's nice to know, do we have to switch them and then take a risk and switch them back? And I think this can help guide us a little further. And with that, I'll take any questions or comments.
Thank you for this nice presentation. So, is there any question here in the room? Not for the moment? Okay. I'm going to read one from the chat. It says, not a diet question, but how do you approach the suspected androgen-dependent cystinuria cases where the owner does not find surgical castration directly appealing, but might agree for supraloin? Do you prefer to use the repeated urine cysteine creatinine ratio or urinary amino acid testing to guide the client in the future decision making? For example, can we see the same effect with supraloin as with surgical dyspnea?
So multiple questions in there. I think the nuts and bolts, they're frustrating. And I have had some clients that wouldn't castrate too. So a little bit is education. Even if it's not androgen dependent, they shouldn't be breeding the dog because we do know that there's a role in genetics. So I try to approach it from that route. If that doesn't work, then we do talk about the possibility of, okay, we're going to change the diet. And recurrence rates can be very high with cystine dogs. And then we can consider, if needed, the addition of something like Thiola. But that too can be difficult to find and quite expensive. So that's really the approach, is the management, just like you would for a dog that is not type 3 androgen dependent. I don't think we have evidence to say we can use any drugs like, finasteride or something in blocking. We have no evidence to say any of that because we don't know the mechanism yet. As far as spot ratios, I feel very lucky. We have a really nice urinary amino acid laboratory at Davis. We usually do full amino acid analyses, and that is how I assess them. I don't have evidence yet on spot ratios. I think that would be interesting to look at.
Okay, thank you. We have time for one more question. Yes, it's this one there.
Thank you. Just for the cystine dogs that are not castrated, do you specifically acidify the urine before sending to the lab? Is it immediate spot sample? How stable is it? And what is the protocol before submitting amino acid profile from plasma and urine?
So we do them fasted. And for us, and I have to check the website, we have been sending them to the laboratory within 30 minutes, but I know there is a process and a protocol written if you need to send them and how they should be stabilized. And I have to go because we take ours right over to be as accurate as possible within 30 minutes. But we do get samples from the outside, and I don't run the laboratory, and I'm looking at someone who does. And do you have that answer, Jed? So for the study, yeah, it's quickly. Correct. We'll get it.
So cystine is notoriously unstable in blood. It seems to be more stable in urine, but we're still trying to figure all that out. So ideally, we would add sulfoxylic acid solution just to make sure that it's stable, but hopefully that won't be necessary in the future because not everybody has that on hand, of course.
And I will tell you that the results from the urine, the normal values are still just, people call me and say, well, what's normal? We don't know. And we're trying to compare right now pre and post. And maybe when we can get some of these, we might have at least some normal values then to look at. There might be some other data sets out there. We're working on including that. Then there is the possibility too on plasma. Our plasma amino acids, I will tell you, and again, this isn't really preliminary stuff. I don't know that we're going to get much from the plasma, but I think the urine has been somewhat helpful looking, again, just pre and post. All I can say right now, but we're close. We just enrolled the last dog with the day I left.
Okay, thank you. Any other question? No? Thanks a lot, Jodi.
Thank you.
And now I will pass the floor to Natalie, but I don't want to leave without saying thank you to the ESVNU to give the opportunity as well to Purina and IDEX to sponsor this great symposium, and as well to the organizers, Natalie, Maria, and Sylvia as well, for the great symposium that we have had. So thank you.
Thanks, Jennifer. So that concludes. Yeah, okay. That concludes our ESVNU symposium this year. Please do join us tomorrow for our stream of lectures in the ESVNU session in the main programme, where we'll have speakers. Jodi will be speaking again tomorrow for us. We've also got some excellent abstracts tomorrow morning and Friday morning. If you're an ESVNU member, please do, I would encourage you to attend the AGM, which will be tomorrow lunchtime, 1:20 to 2:20 in room 114. If I can also just remind you that the welcome reception will be starting at 6 o'clock in the main conference building, the ECVIM welcome reception. So thank you all for attending, and I'd like to thank all of our speakers today and also our sponsors, IDEX and Purina. So thanks, everybody.